Hello, I'm Edward Taylor, Communications and Engagement Officer for Hep C U Later. In today's podcast, I am joined by Louise Hansford and Laura Hughes, Hep C U Later coordinators, who take on the crucial role of engaging teams up and down the country to help them achieve microelimination. We will discuss their roles within the team, their experiences helping people from testing to diagnosis and treatment, as well as the reasons behind their motivation and passion for eliminating hepatitis C. Welcome both of you and thank you for joining us. Question number one, would you both be able to give us a little background to how you started in your current role and what motivated you to apply for the job?
So I guess for me, this role came up and it was something that was really interesting for me at the time to be part of something quite massive, kind of eliminating hepatitis C. It's not every day that you get to be part of a project that eliminates the disease. So I think that for me was the key thing, being able to be part of a legacy of helping eliminate and eradicate disease. I think the other thing was making sure that people hadn't been lost. When I joined, we'd not long since come out of COVID lockdowns, maybe a year after, and there was people that were missing, not missing, but they hadn't been picked up in the treatment, or they'd been lost because of the lockdowns and because of different bits and pieces. So I think for me, it was a part of making sure that people are linked into care as well, making sure that people were tested, and just I guess the overall side of hepatitis C testing and treatment. That was the reason that I wanted to be involved.
So I applied for this role as I am somebody that has previously had hepatitis C, and had I not done treatment, I wouldn't be here now, as I had a serious infection that my liver wouldn't have coped with if I'd still had Hep C. So for me, when I was diagnosed in prison, there wasn't the education or the awareness or the support on offer. So I felt very passionately about engaging with people who needed to be tested, and educating the wider public to break down the stigma and the discrimination that people that access our services feel. So I was running a service in Hampshire called Hep C Hants peer-to-peer project in partnership with the Hepatitis C Trust. So when this role came up, it was the next logical step to be able to take some of the learning and experience from Hampshire into the NHS Addictions Provider Alliance.
That's fantastic, thank you. So, as coordinators for Hep C U Later, can you tell me more about what your role involves, and in particular, what a day as a coordinator might look like?
So, my day-to-day role involves meeting with the different stakeholders across my region. So some of that is done on Teams, some of it can be done face-to-face. What I would say is no 2 days are ever the same. We go to testing events, we go to conferences, we liaise with UKHSA, Office of Health Inequalities and Disparities. So no 2 days are ever the same. There's a lot of networking, there's a lot of bringing different people together. There's a lot of work around data and utilising the data to tell the story of what might be going on and where the gaps are.
Yeah, agreed. There really isn't a typical day, I don't think. And I think even yours and my days aren't typical, Lou. They're so different. This morning, today has been meetings going through different bits and pieces of data. Tomorrow will be meetings, but with different people for different connections or arranging different things. In the pipeline, there's some testing events coming up. So there's a lot of work that goes on around prepping for testing events or treatment events or whatever it might be. But then on the actual days, you won't do what might be considered your day job, so to speak. So there's no day when it's the same. And there's no day when you might speak to the same people either, because the amount of members that we talk with from the APA, so I think we've got 16 trusts that we work with across the pair of us. There won't be one day when we speak to the same people every day. We'll speak to multiple people multiple times in a day. So it's kind of juggling plates and keeping it all together and spinning in the air while we're trying to achieve what we're trying to achieve. So there's never any day that's the same. And for me, that's part of the reason that I love this job, because it's never the same. And even if you've got an idea of what you've got planned for that day, it never happens that way, which I also love, which is random. So I quite like the chaos of it, but there's never a day when it's the same. It just is, it's completely different all the time, but it's brilliant.
So, Laura, we know the treatment for hepatitis C is now far less invasive and has a higher success rate. How has this impacted the lives of those diagnosed with hepatitis C, and has there been a higher uptake in treatment as a result?
So the new treatment, the DAAs, they are a 8 to 12 week course of medication, completely different from what the treatment used to be, which was a year course, quite significant side effects, which, to be fair, the side effects were from people that I've worked with in the past, was what they couldn't cope with. And that was the reason that they came off the medication. The medication now, as I say, is 8 to 12 weeks, little to no side effects, and appears, from kind of people, kind of anecdotal evidence I've been given, appears to be extremely easy. And because of that, I think the effectiveness of that medication is sky high, because there's no inconvenience to it. There's little to no side effects. So I think it's really easy. That doesn't mean to say that people aren't in difficult situations or they're not complex situations. I think what our services that we work with do very well is make an individualized package of care to help people get onto treatment. So again, there's not a one shoe fits all, there's not a one size approach. It is absolutely very individualized care for that person taking that medication. In terms of the other piece of equipment that we have at our hands or at our disposal with Hep C U Later is we have Kefid machines. So currently we've got 2 Kefid machines that we are able to loan out to our APA members. Now, Kefid machines are an excellent piece of kit. They will give an RNA and a viral load within an hour. So when you've got somebody that is short on time, or they're in a really complicated, very complex situation, the Kefid is an amazing piece of kit for us to have. And it means that we kind of hopefully speeding up that treatment of care pathway as well. A test within an hour is incredible. A quick antibody test which will react within 15 minutes and then a Kefid result within an hour. It is absolutely phenomenally affecting how quick we can get people onto treatment pathways.
Well, that's fantastic to hear the testing treatments becoming more effective. So, Lou, can you recall specific relationships you've developed with people diagnosed with hepatitis C who you've been able to see through treatment and have had a significant impact on their lives?
Yes, potentially far too many to talk about in this podcast, but there are a few that really stick in my mind. So there was one guy, I'll call him Fred, whose wife lived in Thailand, and he knew he had hepatitis C, but at the time, prior to Hep C U Later, Laura just talked about pathways and getting people in quickly and onto treatment. Fred had literally every time he was back in England, he would ask for a hospital appointment, and invariably that hospital appointment would come through when he was back in Thailand. And one notable occasion, I was chatting to him and he just said he's done. He wanted it treated. He'd had Hep C for over 20 years and he was going to buy the medication in Thailand. And I begged him not to, and suggested and arranged for him to come to the next outreach clinic where he was prioritised, because by now this had been going on about 18 months with my involvement. When he came in, Fred had a fibre scan, which is another diagnostic tool that we use, and his fibre scan was 75. Normal range is 0 to 6 or 7. Fred had liver cancer. So ironically, if he'd bought the medication in Thailand, it may have cured his Hep C, but he would have died very imminently at that point from liver cancer. He was successfully treated, and I mean, sadly, he's passed away now, but that intervention did give him another 3 years of his life. There's another guy that 30 years he'd had Hep C, was really resistant to coming into services. He felt stigma, he felt discriminated, against. So I utilised my kind of just my care and compassion really, and I rang him several times, and he came into the doctor's surgery where I was working. We did some bloods. We on the Kefiad. We pretty much got him onto treatment. He's done a video for us. He looks completely different. He's done a video that has been played to other people talking about how scared he was, how resistant he was, how ashamed he was. And just that video and that audio that's associated with it has enabled other people to take their treatment. I mean, I honestly, I could talk about the people that, again, another man, I'll call him William, long-term abstinent recovery, had just missed the testing initiatives. His doctor, there was a letter on his file. So the office formerly known as Public Health England wrote to everybody that had ever had a hospital laboratory test done that was Hep C positive or indicative of further diagnostic testing needed. And William had one of those letters. The GP referred directly to the consultant. 18 months later, William still hadn't been seen through Hep C U Later initiatives. We again used a Kefiad test and he was on treatment within 2 days. He's somebody that doesn't ever remember being tested, doesn't remember being given the results, and would have had Hep C for 17 years plus. There's, I mean, I could literally talk for hours about different people. There's another lady who injected drugs throughout her treatment, and at the end of it, she had a wake-up call, and she realised that for the first time in 35 years, she had done something and taken responsibility for something on her own through her own choices. You know, she's now in long-term abstinent recovery, volunteering in inclusion services. So yeah, they're just a few. You know, it's not, I think Laura alluded to, it's not just about the Hep C, it's about how this intervention and the care and compassion people are shown that really empowers them and motivates them to make other changes within their life and really improves their overall quality of life.
Thank you for sharing this with us, Lou. It's great to hear the work you guys are doing and having that impact on people and their lives. If you would like to know more about the testing, treatment and elimination of hepatitis C in England, we have multiple resources available to you. Some of these resources are specifically aimed at professionals and patients within primary care, such as the Primary Care Toolkit, CPD accredited training, posters, leaflets, TV screen graphics, as well as other materials which are all free to download and use. So Laura, across Hep C U Later, we have been lucky enough to work with and help services reach microelimination from Buckinghamshire to Merseyside. Could you explain to anyone listening what exactly microelimination means?
Yeah, so there's 4 criteria for microelimination. So the first one is 100% of people that use service have been asked and offered a test. They can refuse it, that's fine, but they need to be offered a test at least. The second criteria is 100% of those people that have a current or previous injecting drug use have had a test ever. So it could be yesterday, it could be last week, it could be 25 years ago. They just need to have had a test ever. Criteria 3 is that 90% of those people with a current and previous injecting drug use history have had a test within the past 12 months. And that is actually quite difficult because that could be a rolling 12 months. There can be people that would have a test and that they kind of drop out of that criteria quite quickly. So that's quite a difficult one to achieve. And criteria 4 is 90% of those people that are RNA positive have had treatment for hepatitis C. Then we look at those that are antibody positive and we as well as the RNA positives, and we calculate that accordingly to make sure that we're not missing anybody. And as Lou kind of said at the start, alluded at the start, a lot of our work is around the data, and the data really does underpin the work that we're doing to help target interventions towards individuals, whether it's for testing or for risk reviews to see whether they've actually put themselves at risk or not. So those are the 4 criteria. And I think it's worth pointing out and worth highlighting here that across the APA and the Hep C U Later services that we work with, we've had 50% of our services now achieve microelimination, which is an amazing feat. And there's a lot of hard work that goes into that, and that's not just the data that underpins it, but it is the testing and the treatment, and we can't have one without the other. So it really is a joined up effort from everybody involved.
Thank you for breaking that down for us. So last but not least, Lou, for anyone listening to this that is keen to start eliminating in their area, is there any advice that you would give them?
Yeah, I just think there's so many resources, both written resources, like people resources, testing resources, that there's never been a better time to eliminate hepatitis C, and there's so much available. So I think really it's about kind of understanding what already exists in your areas, and Laura and I can definitely help with that, because we're up and down the country, and we if we're not in an area, we know who is, so we can definitely signpost people. You can carry out testing events, and there's lots of different ways that you can do that. There's different ways of finding people who may be been at risk of Hep C. So the GPs are coming together now to do some GP case finding work. There's algorithms that have been developed to do that. So I think what I'm saying, Eddie, is that there's a wealth of resources out in the community that and tried and tested ways. So please do just check out Hep C U Later resources and our website and our training. And if you've got any queries or questions or want some advice, please do reach out to Laura and I.
Well, thank you so much for joining us today, both of you, and for all the work you're doing to help eliminate hepatitis C. And thank you to everyone who has listened to our podcast today. If you'd like to know a little bit more about how you can get involved, please email us at connect.hepculater@mpft.nhs.uk.